For the grand round, we have three speakers, our Academic FY2 doctors. We have Faith, Heather and Laurianne, and they're all going to talk about projects they've been doing. They're going to talk for about 8 minutes each, and then there'll be an opportunity for questions after each talk. So without further ado, Karen's going to introduce the projects. Okay.
Hiya. My name is Karen McKelvey. I work in clinical skills and I'm partly involved in the Academic FY programme with Claire McRae, who's our Staff Development Officer here. And we run sessions for the Academic FYs during first and second year. And for those who don't really know about the Academic FY programmes, we've got a total of 12 doctors in between FY1 and FY2 year, and we have 6 of the academic FYs in year 2 at the moment. And during their FY2 year, they get 4 months out of programme to go and do a sort of research project of their choice. And today's sort of a session really is about Laurianne, Heather and Faith sort of showcasing their project and giving you a bit of insight into what they've gained from doing the Academic FY programme. So rather than me chatting, I'm going to hand over to Faith Dalgetty, who did a research project on pain management, and the title of her talk is going to be The Role of the Reactive Oxygen Species in Phototoxicity.
Hi there, so my name's Faith. I'm currently about halfway through my academic project, still undertaking some experiments at the moment. I chose to do a research-based project, and I've been working in the Institute of Academic Anaesthesia. My supervisor is Professor Tim Hales, and I've been looking at the role of reactive oxygen species in phototoxicity. Phototoxicity is important in clinical medicine. It's involved with a number of adverse drug reactions. It is a phenomenon that's associated with the pain and burning and blistering reactions in porphyria, and also the phototoxicity can be utilised in photodynamic therapy to its advantage, where cells are targeted and killed by light therapy. So the format of the talk will just a quick overview of the project, some of the results that I've gained so far, and then take a different slant into some of the learning outcomes and goals that I was hoping to achieve during the block. And to speak a little bit about some advice to future students considering the academic programme, to foundation doctors whilst they're doing their programme, and potentially to some supervisors of foundation doctors. And lastly, acknowledging people and open for some questions. Photodynamic therapy is a widely used therapy for non-melanoma skin cancers, actinic keratosis, but can also be used in other cancers such as lung, brain, esophageal and leukemia. It involves the application of a prodrug such as ALA or MAL. These accumulate in rapidly dividing cells and are metabolized in the mitochondria to protoporphyrin 9. Protoporphyrin 9 is the penultimate product in the heme pathway. A light is shown, and the light activates and causes reactive oxygen species to produce. Mainly in PDT, it is singlet oxygen as a reactive species. The singlet oxygen causes localized destruction of cell membranes, DNA, and mitochondria. This treatment is very successful. In a few rounds of treatment, you can have destruction of your area of interest, but as a consequence, a painful phenomenon is experienced. Patients report a burning or tingling or prickling type sensation when they're undergoing therapy, so much so that during this therapy that they have to often discontinue it due to the side effects. There are a number of analgesics that are currently used with limited effect. We can use anti-inflammatory painkillers, cooling spray or air. As the mechanism of pain is not fully understood, these analgesics are not specific and are largely ineffective. The lab that I've been working in has started looking at the mechanism of the pain with the view of developing analgesia to target this. And I have joined the project partially way through. So I'm just going to introduce the idea of what they propose as the mechanism of the pain, and I will explain this through some data that the lab has previously collected, and to introduce ideas of the mechanism. in the... I can't get the PowerPoint to work. If you see this line here, this is the action potentials generated when you apply ALA, which is a prodrug, to the laser. You can see the spikes there, which are action potentials in afferent sensory neurons, dorsal root ganglion neurons. TRPV1 ion channels are responsible for the sensation of heat-type pain or inflammatory-type pain. When we use an antagonist of TRPV1 receptors, we can see that the action potentials are largely abolished. This implicates the role of TRPV1 receptors in the mechanism of the pain. Also, I'd like to introduce the idea of the role of reactive oxygen species in the mechanism of the pain. The scavenger of singlet oxygen, L-tryptophan, increases the dose of light required to initiate the action potentials. However, an alternative scavenger, Tempol, does not. This specifically implicates the role of singlet oxygen. We then went on to we'll then introduce the idea of lipid metabolism. Metabolites of lipids can activate TRPV1 receptors. So if the anandamide and arachidonic acid can activate TRPV1 receptors, and a fatty acid amide hydrolase inhibitor can block this process. However, it can also reduce our action potentials. Importantly to mention, singlet oxygen has a tendency to oxidize lipid metabolites. And lastly, I'll introduce the role of keratinocytes. The addition of keratinocytes to dorsal root ganglions decreased the light dose required to initiate action potentials. This suggests that the HaCaT cells have a role to play in the initiation and the phototoxicity reaction. So if you bring this all together and have to bring the ideas together into a mechanism, the hypothesis in the lab would be that there's an noxious stimulus going along the afferent neurons into the spinal thalamic tract to the thalamus in the brain. We were quite interested in what's happening at this point. If we magnify it up, you can imagine this is the light stimulus at the top, shining onto pre-treated skin cells with the prodrug. Protoporphyrin 9 accumulates in the mitochondria, is activated by light, and energy is excited into its singlet state. From there, we propose that it oxidizes lipid metabolites, and one of these lipid peroxidation products would activate TRPV1 and send signals along the TRPV1, along the primary afferent neuron to be sensed as pain. So what I have been looking at specifically in this project is to examine what drugs modulate the arachidonic acid metabolism and affect phototoxicity, the role of keratinocytes and reactive oxygen species in cellular phototoxicity, to produce and measure some effects of reactive oxygen species in vitro, and to explore some scavengers of reactive oxygen species in cellular phototoxicity. This is the start of my results, and we initially took hydrogen peroxide as a means of generating reactive oxygen species, and we applied increasing doses of hydrogen peroxide to HaCaT cells, which are the keratinocytes or skin cells, and performed a viability assay. The cells were treated for 48 hours, increasing doses, and at that time a drug called MTT is applied, which is a method of assessing cell viability. In cells which are alive, the drug is reduced in the mitochondria to NADPH, and a purple precipitate is formed, which can be a detergent is used, and the purple precipitate can be made into a colourful solution. So the more colour, the more purple the cells, the more viable they are. And by a colorimetric assay, the purpleness can be given a value. Here plotted on the graph, increasing doses of hydrogen peroxide reduce the cell viability of the HaCaT cells. So we're interested in what happens when you apply reactive oxygen species scavengers to the mix. We can see that L-tryptophan, which is the single oxygen scavenger, does not have a significantly different effect on the control cells. However, another type of reactive oxygen species scavenger, Tempol, which is a superoxide scavenger, has a significantly increased difference. We know from the previous studies that single oxygen is more implicated in the production of the pain, so we went on to examine a better way of examining specifically single oxygen. You may have heard of methylene blue as its role as a histological stain. It is a stain often used as a viability. However, it is also a donor of single oxygen when exposed to light. So for this experiment, we examined HaCaT cells with methylene blue and exposure to light. In the first cells, these cells are not exposed to any methylene blue or light generated by the lamp. We'll examine them under the microscope for signs of damage, which they appear to be healthy. The next section of cells are cells that are treated with ambient light. They also appear healthy. The next slides are treated with 1 millimole of methylene blue. You can see the role of methylene blue as a viability assay. It is known to stain RNA and DNA blue. If I can convince you that I don't know how well it projects, but the nucleuses of these cells are blue. In alive cells, the enzyme can be reduced and cleared from the cell itself, indicating that these cells are viable. However, when you expose methylene blue to the cells with light, you can see that the blue stain is taken up throughout the cells. This indicates that the cells are dead. However, this is a very crude assay. It doesn't quantify the amount of viability or cell death. So we then went on to use the MTT assay to quantify the viability of the cells. So methylene blue treated only cells have an arbitrary value of about 0.7. However, methylene blue and light significantly reduces the number of viable cells remaining. We then went on to perform a dose response with increasing exposure of light to the HaCaT cells in methylene blue. You can see from the increasing time that the cells become initially blue in the nucleus, indicating they're alive, and when it becomes minutes, they become more blue throughout, indicating they're no longer viable. With the MTT assay, this can be then plotted as functions of time. The number of viable cells reduces. Specifically in the 18-hour window, there's a remarkably big reduction. The IC50 is around 26 minutes, indicating that the cells are becoming less viable quickly by Singlet oxygen. The experiments I'm now moving on to do are using this methylene blue experiment with scavengers of reactive oxygen species, and then we'll go on to use some lipid metabolites and inhibitors. So taking a slightly different slant, at the start of this block I set out some outcomes and goals. I had a pharmacology integrated as a medical student where it opened my eyes to research, and I wanted to build on some of the assays and skills I'd learned during this block. During the time in this lab, I've learnt some things about electrophysiology, become more proficient at cell culture, and we'll hope to learn some behavioural studies in the next few weeks. I really enjoyed engaging with a topic in detail in my BMSc project, and have learned a great deal about photodynamic therapy, but also about reactive oxygen species, which I find its wider applications of very interesting. I wanted to create and generate some data and generate some figures, also to present findings at things such as this. A larger goal would be to improve data handling and knowledge of statistics. During this course, we've been offered a weekly statistics course by Professor Peter Donnan, which has been very useful in helping me understand the data I'm creating. I also wanted to write a review of the topic and spend some clinical time in ICU and anaesthetics. This block of time has also given me the opportunity to develop some of the teaching projects I've been in, and also the opportunity to sit some postgraduate exams and keep my head also in a clinical way. If I was offering any advice to future students or doctors undertaking this project, I would encourage you to apply, even if you don't consider yourself an academic person. You've got to start somewhere, and I think labels are often misused. I think you should be open-minded to suggestions. You never know when a good idea will come and present itself to you, and often things that I've been involved with have been by accident. I think early project planning is also essential for something like a laboratory-based project, and particularly with a laboratory-based project, resilience to failure is important. When an experiment fails, quite often people come disheartened, but you should really look into the reasons why it's failed and develop an assay or change something. I spoke with my supervisor about potential advice to offer other supervisors. We considered that having other PhD students and postdocs around created a healthy atmosphere and was good for when you wanted to ask questions on experimental procedures on a day-to-day basis, but also creates a good atmosphere for discussion around scientific topics. Also, we felt it was important to have a project which was central regarding themes and interests of your lab. If everybody has a role in your project, the momentum is continued and you're absorbed in the action. I have a large list of people to thank. Over the last 2 months I've been exposed to a variety of people, all of which have helped contribute to this project. My greatest thanks goes to Professor Tim Hales for agreeing to take me on for the last few months, and also to the guys in the lab that have been an excellent source of help. Also to our collaborators who have been involved previously with the Photodynamic Therapy project, Dr. Sally Ibbotson and Dr. Julie Woods, and also to Professor Marshall for being that person who pointed me into the right direction, Dr. Paul Fettis for helping organise my clinical time, Professor Peter Donnan for helping with the statistics and unravelling the mystery, and also to Dundee Clinical Academic Track for taking me on. And that's it. Any questions?
Thank you. Any questions? Bring your microphone. No questions. Huh?
Thank you very much indeed. Well done. Nicely presented.
Thank you.
I'm a sort of clinical researcher, not a lab researcher. And I wonder if you can explain something about the approach to statistics with laboratory outcomes. Because what happens in clinical research is we apply a statistical measure, we get a p-value, and if it's significant, we ask ourselves, is that finding of clinical significance? Because that's what actually matters, not statistical significance. So I wonder if you do an equivalent thing in the laboratory. So where are the differences that you were showing important in terms of laboratory findings? That's my question.
It's a very good question, and something that Professor Peter Donnan has emphasised quite a lot. He asks, there's too much onus on p-values. They asked us the finding is important, not necessarily significant, and that's something I'd not previously thought of, and do take on board perhaps if the numbers aren't quite right, is what is happening here important, not necessarily significant, and go from there really. But I think it is largely a huge part of science work and in academic research projects to acknowledge statistics and if it is significant or not. I hope that answers your question.
Anyone else have a question for Faith? Okay, thank you very much and well done.
Thank you.
Okay, I'm going to pass over to Heather Walker, who has done a project looking at kidney failure, and our title of our talk is Acute Kidney Injury and Surgical Prophylaxis. Heather.
So as Karen said, I'm going to talk about acute kidney injury and its associations with surgical prophylaxis, but also touch a bit on the Academic Foundation programme. So I'm just going to talk a bit about my expectations coming into the Academic Foundation programme and what I wanted to achieve, and then a bit of background about my project, what we found, how we carried it out, and then outcomes both with the results of my project and of the Academic Foundation programme, and then finish with some tips for future Academic Foundation trainees. So why did I want to do the Academic Foundation programme? Why did I want to stay in Dundee? I'd previously been exposed to research both in my BMSc and in my fourth year project. It was something I enjoyed. I liked finding things out, sort of that problem solving type thing. I felt the academic programme would give me opportunities to carry out further research and open opportunities that are not necessarily there during the normal foundation programme. I also felt that Dundee is one of the few places that offers a 4-month isolated block where you have that dedicated time to carry out research. A lot of other places just give you a half day where it can be a lot more difficult to get that time to carry out the research that you want to do. I also felt that it would give me the opportunity to exposure to the speciality of my choice, so I'm interested in renal and was able to work with the renal team for 4 months. And I also felt that it would offer some time and self-management so that I could pursue things such as teaching and quality improvement that I'm also interested in. So when I came to my 4-month block, I wanted to be able to write a research protocol. I wanted to manage data within a safe haven environment. I wanted to develop skills managing a large data set using SPSS, which is a statistical package, and develop my statistical analysis skills using an interrupted time series analysis, which I'll talk a little bit more about later on. So a bit of background to the project I was involved in. The Scottish Government in 2009 released targets to reduce the rates of C. diff infection over the following 2 years by 30%. And relating to this, the Scottish Antimicrobial Prescribing Group made recommendations to reduce the use of antibiotics that were associated with a high risk of C. diff infection. Across Scotland, there was a change in antibiotic policy, and within NHS Tayside, cephalosporins were replaced with gentamicin. And as part of this, the orthopaedic surgery antibiotic prophylaxis policy was changed from cephalosporins to flucloxacillin and gentamicin. Following this, a group of nephrologists in Dumfries and Galloway raised concerns about the rates of acute kidney injury. So they'd carried out a small uncontrolled study that had showed that patients who'd undergone orthopaedic surgeries who'd received flucloxacillin and gentamicin as their antibiotic prophylaxis were associated with an increased rate of acute kidney injury. NHS Tayside had the access to the appropriate data through the Health Informatics Centre to carry out a more robust study to look at the rates of acute kidney injury. And what they showed was that following a change in the antibiotic policy from cefuroxime to flucloxacillin and gentamicin, there was an increased risk of acute kidney injury, and it was as big as 94%. They'd showed that it was 94% increase in the rate of acute kidney injury. So why is this important? You'll probably all now be aware of the acute kidney injury alerts and have heard a lot of information about it, but there has been an association with acute kidney injury and the longer term mortality. It has obvious longer term effects, and the socioeconomic and public health effects of that has a big impact on us. So anything that we can do to reduce acute kidney injury is obviously a good thing. So these findings were fed back, and this resulted in a further change in Scottish policy. And within NHS Tayside, the orthopaedic antibiotic protocol changed to comoxiclav instead of the flucloxacillin and gentamicin in June 2012. So the work that I was involved in was aiming to check that following this further change in policy, that the rates of acute kidney injury were decreasing, and to ensure that the rates of C. diff infection were not increasing. And at this point, it's worth saying that there was a group of patients who'd undergone neck of femur repairs that had previously been identified as a high-risk group of patients that didn't receive gentamicin. And so in the previous study that I spoke about, they were used as a comparison group because they received comoxiclav throughout the study period, and there was no change in acute kidney injury within that group. And they went on to continue to receive comoxiclav. So again, we're a good comparison for us to make with. So the study that I carried out was an observational study using large linked database, and it looked at patients who'd undergone orthopaedic surgeries between October 2008 and December 2013, so encompassing the period where patients had received flucloxacillin and gentamicin and the period where they'd received comoxiclav. And we used an interrupted time series analysis to assess the rates of acute kidney injury. So this is a good design method that can be used to assess interventions in an unrandomised setting, such as policy change. And it allows us to control for trends before an intervention by looking at multiple time points before and after an intervention. For the C. diff infections, there were actually quite a small number of C. diff infections, and in some months there were no cases of C. diff infection, so we used an incident rate ratio to assess for change in C. diff infection. For post-operative renal impairment or acute kidney injury, we used the Kidney Disease Improving Global Outcomes AKI criteria, which, again, because of the AKI alerts, I'm sure a lot of you will be aware of, but essentially splits acute kidney injury into 3 stages. We were interested in just looking at any acute kidney injury, and so defined it as an increase in creatinine more than 26.4 micromoles per litre, or an increase of more than 150% from the baseline. And what we showed was that patients who'd received comoxiclav rather than the flucloxacillin and gentamicin were associated with a decreased rate of acute kidney injury. And 18 months following a change in policy, there was a relative decrease in the rates of acute kidney injury by 63%. And there was no significant change in the rates of C. diff infection. So you'll remember earlier the sort of things that I'd set out to achieve in my academic programme. So I managed to write a research protocol. I managed a large data set within a safe haven environment. I developed my skills managing a large data set within SPSS. I developed the statistical analysis skills to be able to carry out an interrupted time series analysis. And in addition to this, I'm in the process of submitting a paper for publication and presented the findings back to the Scottish Infection Intelligence Platform meeting, which are part of the Scottish Antimicrobial Prescribing Group. So I'm not going to pretend that it was all easy and there weren't any barriers. I think with most research you do come into some barriers. Despite the best planning in the world, there was problems getting access to the data at the start of the project. I was lacking in experience with large data sets. I'd never worked with them before and I'd never used SPSS before, so I relied heavily on statisticians and other analysts and a lot of reading to develop my skills within SPSS, but I think it was definitely worth the time and the ability to learn these skills. And I think probably the thing that was hardest was just to complete the standard foundation programme assessments within the academic block, so you don't get as much clinical exposure, and so to be able to carry out the normal clinical assessments such as the DOPS assessments and the mini-KEXs is not as easy as it would be if you were taking part in a normal clinical block. So just some tips for future academic foundation trainees, which sort of overlap with what Faith has said. Definitely planning is important. I first contacted my supervisor when I was in 5th year and knew that I was coming to do the academic programme in Dundee, and getting sort of ideas and what you want to do out on the table so that you can find something that interests you is important. As Faith said, you will come across barriers. Things don't always go right, and it's important that you're interested in what you're doing and sort of problem solving and finding out why is this not working, or how do I manipulate my data to do what I want it to do. And I'd say network and work with others. I learnt lots of skills from the people that I was working with and got ideas about what I was doing. And I'd say definitely utilise opportunities and resources available to you both through the university and NHS Tayside. So just to conclude, we've shown that a rise in acute kidney injury rates is now resolving following a further change in antibiotic policy, and avoiding gentamicin and flucloxacillin as orthopaedic antibiotic prophylaxis can reduce the rates of acute kidney injury. This database linkage project has allowed monitoring of the intended and the unintended consequences of a policy change, and has changed patient outcomes. And I would say that the Academic Foundation programme is definitely a worthwhile opportunity and experience for anyone that's interested in doing it. And I would just like to thank my supervisor, Samira Bell, and then a lot of other people that are heavily involved in the project, Andrea Patton, Gwen Bain, Gareth Marrick, who's here today, and also the Health Informatics Centre, who linked and anonymised all our data for us. It's just some references for anyone that wants to do some further reading. I'm happy to take any questions.
Any questions? Go ahead.
Yes, thank you. Oh, well, that's it. Good. Thank you very much indeed. Well done. Another nice presentation. I wonder what ethical considerations you took into account before you embarked on this project. So I'd be interested to hear about that, because accessing anonymised data is a very hot topic, particularly in England, where they've really botched up the whole concept of access to routine data by annoying the dickens out of GPs and the general public. So I'm interested in that. And I'm interested to know if you think there was an ethical duty incumbent on the doctors administering flucloxacillin and gentamicin, which resulted in acute kidney injury.
Thank you. So first of all, I think you're right, there is a lot of interest around using data that's available to people for research. I think as long as it's stored in a way that is safe and is anonymised in an appropriate way, I think that it is important that we use data that's available. Otherwise, it's going to waste. And when we can show that database projects such as this can make changes to patient outcome, that it is important that we do use that data. With regards to your second question, I think it wasn't just the group of nephrologists within Dumfries and Galloway that had identified a concern with administering the flucloxacillin and gentamicin. There was other groups, and so I think there was other people that actually had looked at the association between the two, but it was just that NHS Tayside had access to that appropriate data to sort of say, yes, there definitely is a link. But there was a big time delay between that sort of those first initial concerns and the final information coming out saying yes, there is a change and us changing the policy, and I think that's something that we need to work on in the future. And the infection intelligence platform that I mentioned, I'd presented the findings back to. One of their main aims is looking at information database in a sort of more proactive, timely manner, so that we do pick up these changes in policy and whether they're having the intended effects that we want them to do, but also looking for the unintended consequences, such as the acute kidney injury in this case.
Any more questions? Okay, thank you.
Okay, our last presentation this afternoon is by Laura Ann Etherington, and it's a project she undertook looking at academic psychiatry, so another diverse topic. Okay.
Okay, thank you very much for coming today. My name's Laura-Ann, and I've been working with the supervisor, Professor Keith Matthews, in the field of academic psychiatry. And I'll give you a very brief overview of what I've been doing and then talk about what it's meant to me and any tips again for people thinking of embarking on this. So in terms of psychiatry, unfortunately, it's not a very prestigious specialty, and even less so for academic research. It's also largely misunderstood by the general public. And as you can see here, this is a picture of a demonstration outside the Royal College of Psychiatry meeting on Princes Street in Edinburgh only a few years ago. So hopefully after this I can inspire some people here that this is actually an exciting area to be involved in. So my first slide is really to illustrate and highlight the large scale of psychiatric conditions in the population. The bottom three bars there you can see are schizophrenia, bipolar disorder and unipolar depressive disorders. However, if you take a look here, I've highlighted both Parkinson's disease and epilepsy, and these actually receive much more public funding, public interest, and have devoted specialist services compared to these other mental health disorders. I've personally been working with the team in the Advanced Intervention Service. It's based up at Ninewells. This service is a national specialist service providing assessment and treatment for severe and chronic treatment-refractory depression and obsessive-compulsive disorder. The aim of what the group does is to provide patient review, so this might lead to helping with thinking about underlying diagnosis after patients have been treated for many years, and also advise on some further treatment recommendations for their psychiatric team. Also might consider patients for physical interventions such as vagus nerve stimulation, deep brain stimulation and anterior cingulotomy, and see those patients both through to surgery and then beyond as well in terms of follow-up. Also offers psychological interventions and has a facility for bringing people in for intensive treatment programs, and also heavily involved in research. So this is an overview of all of the different things that I'm also currently halfway through my placement, and these are already the things that I've been able to be involved in. So started out being able to critically review journal articles that are not yet towards publication and discuss my findings with my supervisor so I could enhance that skill. I've been working on a literature review which looks at the long-term follow-up of patients with obsessive-compulsive disorder. Been able to do oral presentations, obviously today, and also within our clinical meetings that we give. We have a case presentation and poster submission that's been put forward, and the title of that is Sustained Clinical Response to Ablative Anterior Cingulotomy Following Failure to Respond to Vagus Nerve Stimulation and SG25 Deep Brain Stimulation. I've been able to be involved in writing clinical study protocols, which has been very beneficial to me, and there have been 2 of these that I've been working on, one of which in the next slide I'll take you through in a little bit more detail. And I've also been able to co-author some position statements for the Royal College of Psychiatry on vagus nerve stimulation, deep brain stimulation and anterior cingulotomy. So this is an example of what I've been doing, and this is a clinical study protocol development from patient data relating to electroconvulsive therapy. So ECT, or electroconvulsive therapy, involves the electrical induction of generalized seizures under general anesthesia, and the principal indication is for the treatment of major depression, although not isolated to this indication. So in Scotland, approximately 400 patients receive a course of ECT each year, and data pertaining to each of these patients, which includes the indication, the side effects, the type of anaesthesia, and much more, has actually been routinely collected for the past 10 years from the 19 treatment centres that deliver this across Scotland. So the data is collated by the Scottish Electroconvulsive Therapy Accreditation Network, also known as SEAN, as you can see in the picture here, and it's held by the Information Services Division of NHS National Services Scotland. And although comprehensive reports are actually produced yearly, the database has not been used for research purposes to date. So the question that we've come up with to ask of this and to review in terms of the database that's available is looking at ECT treatment and the side effect of emergent mania in some patients, and then asking the question, should the course be stopped or continued? So the first point of this would be to get an overview, a landscape view of what's actually happening. Do people actually stop the course currently and treat with mood stabilisers, or do they just continue with the whole course? So that's obviously the first step of this, and once we understand the data a little bit more and what the procedure is, this might lead on to developing a proposal for a Scotland-wide randomised clinical trial where we could then compare continuing ECT versus pausing and introduction of a mood stabiliser. So concurrently to this, when you do the academic programme, you're meant to have approximately a day a week that relates to clinical experience. So in this time, I've been able to observe new patient assessments and reviews with the team, and this has covered variable places in across Scotland. We've been up to Aberdeen, Falkirk, and then also seen patients in Dundee. We take part and involved in a weekly MDT clinical team meeting, which is every Thursday afternoon. And during this, patients are presented the process of following patients either for further intensive treatment or pre- and post-surgery are discussed, and also research topics are brought up as well. I've been able to gain an insight into psychological therapy and exposure response therapy and how that is delivered to patients. And then also, as an aside, I've taken some time to just do general medicine shifts. My previous placement was also in GP, and I did that then just to keep my hand in with hospital medicine. So on reflection for me, I have to admit I have gained more from the academic foundation placement than I perhaps expected to. I've really enjoyed it, and I've been able to tailor it to my progression in clinical research. As you can see, I've taken a rather laborious route to be here today. So I've got quite a grounding in basic science from my previous work, and now I'm trying to make that more translational for me, and I found that this has been hugely beneficial in order to do that. And now following on from here, start core psychiatry training in Tayside next, and I'm hoping to apply to a junior Screds course so that I can have some time to continue the research, which hopefully would lead on from one of these grant applications that we're forming now. If there's any students out there listening to this, my advice is very similar to what Heather and Faith have already said, that if you're interested in research at all, then apply to the Academic Foundation programme. In terms of applying, it can't be detrimental. It's prior to the foundation programme application in general, so even if you're not successful, it doesn't affect anything. Dundee offers the 4 months protected time, so you can get embedded in a group and understand your research really well. As you can see, we've all talked on really diverse topics today, and there's more to that as well. So you might do basic science research, clinical research, and some people have taken the time to do qualifications in education. The academic placement is in your second year, so there's plenty of time to find a supervisor, think of a project, discuss it. Not all supervisors are aware that it exists and you can find out what you want to do, but do this earlier rather than later so you can come up with some good ideas, and be prepared that project plans might change, but that's not a bad thing as well. I'd like to thank the supervisor, Keith Matthews, and the rest of the Advanced Innovation Service team. Thank you for listening.
Thank you, Lorianne. Any questions for Lorianne?
Well done, thank you very much. Nice, interesting presentation. I wonder, as at an epidemiological level, if having a generalised seizure is a therapeutic thing for emergent mania. That's what, did I pick you up correctly? That's an indication, is it? Or severe bipolar disorder?
Yeah, it's currently used, the main indication is for major depression, and we're saying that it's almost a side effect that emergent mania would come out.
Okay, I misunderstood you. Okay,
Mm-hmm.
So major depression.
Yeah.
Is there epidemiological evidence then to suggest that if you suffer from epilepsy with generalised seizures that are poorly controlled, you are less likely to develop major depression?
I think with my understanding, although I can't give you a clear answer on this, is that actually epilepsy probably has quite a high proportion of people who are concurrently also depressed. So I don't think that the fact that you would have concurrent seizures would necessarily mean that you don't have it. I think that they could potentially be more comorbid, but although you're having generalised seizures, they're not in this controlled fashion either. They're not done under general anaesthesia. The way that you're delivering it is controlled and limited as well in terms of duration. So,
anyone else have a question? Okay, let's finish there and thank all three speakers in the usual manner. Thank you. I just going to do that.
Definitely, we're really interested. Really interested. It's been a while.